Okay, so when we were talking yesterday, I was talking about topical or like where you splash the agent on, and that's only giving you superficial loss of sensation. You can also put it around a wound, around a site, and if you're going on a local site, that's called local infiltration. And then there are nerve blocks. And when you do a nerve block, you are trying to block a series of like roots of nerves. Now, a nerve root controls a larger area. So when you're blocking at, and usually these are at specific anatomical sites, because when you block at an anatomical site, that's where a nerve root comes out. And so, for example, when we do dental blocks, I started to explain this yesterday. If you're blocking near the zygomatic arch and you do, there's a block, it's called an infraorbital, and you can put the needle kind of at the end of the zygomatic arch, and that's where the infraorbital nerve exits. If you remember, when we did the bones and we did the skull, and I talked about a foramen, there's little holes in the skull, and that's usually where blood vessels and nerves come. And the way you find those spots is you find those anatomical landmarks. So if you go to the most rostral part of the zygomatic arch and you feel where that ends, that's kind of like their cheekbone area. If you put the needle in there, what you're doing is you're bolusing a deposit of the local anesthetic. There will be an amount that's calculated and you put it in. And then what you're doing is that nerve root is going to split into smaller nerves, kind of like a blood vessel, like a major artery splits into arterioles. A nerve is going to spread out into peripheral nerves. But if you block the primary nerve, then you're going to block all of those, you're going to block an area. So I do want you to be familiar. You know, if I say a dental block, we're obviously going to be, blocking anywhere near the skull, near the zygomatic arch. An intercostal nerve block, well, inter is between and costal is rib. So this would be putting the agent in the muscle in between the ribs where those nerves come out to control that area. A limb amputation, usually, like I talked about, a forelimb amputation, you go into the armpit area, which is called the brachial plexus, and the brachial nerve root emerges there, and you're going to block the brachial nerve. Now, a cat declaw, we will sometimes do what's called a ring block, and if we put a ring, so normally it's kind of like a line block, because what you do is you inject into the carpus area, right under the skin, and what you do is you start to squirt the lidocaine and you pull your needle back as you're pushing, because you're kind of squirting it all along that area. And then you do the same thing on the ventral aspect of the carpus. That essentially forms a ring of lidocaine, and then that blocks all the nerve roots going to the paw. And then you can do, so that's what a ring, so a ring block is literally like a ring. And then paravertebral blocks, and let me see if I can, let's see how I can do this. Okay. Okay, I don't know if you can, excuse me, see this diagram, but here's the lateral aspect of a cow. So a paravertebral block, sometimes it's called an inverted L, because you can put the block, well, there's paravertebral, para, bi, vertebral, vertebrae. And what you do is you would find the last rib, and then you would palpate the dorsal aspect of the vertebrae, and then you feel the transverse process. And at the transverse process is where that nerve comes out. So they'll give an injection at each of these processes. And what it's going to do, it's going to block all these nerves. And so the whole flank is numb. So you can do a C-section. So maybe like here's a better picture anatomically. So normally obstetric procedures like a C-section, or sometimes you guys are in large animal. So I don't know if you've talked about the abomasum. Well, I mean, I talked about it in anatomy, but you know, cows can get what's called a displaced abomasum. It's where their stomach kind of turns. It's not necessarily bloat like in dogs, but if it gets displaced, it's called an LDA, then the doctor has to go in and reach in the abdomen and kind of twist it around, and then they usually kind of tack it to the body wall, kind of like we tack a GDB. After we untwist a GDB, we usually do what's called a gastropexy, and that's where we affix the stomach to the body wall so that dog maybe won't twist again. So in cattle, you may have to do an LDA. And so here's an example of, you know, the last rib would be right about here. And then here's the dorsal processes of the lumbar vertebrae. And then the doctor can feel, if you remember, the vertebrae have these wings that are like the transverse process. And if you feel those, that nerve comes right out. So what the doctor will do, will feel that area, inject kind of like a bubble or a bleb of lidocaine, then go to the next one, let us sit for about 10 minutes, and then it'll be blocked. Now in this cow, they actually kind of drew, you know, the cow is shaved, and you can see they've kind of traced where the transverse processes of the vertebrae, and they've kind of drawn these lines. These would be the nerves. And here's an example of where they would place the needle. So they can either put it above or below. Usually they don't do both, but they can put the drug there, and that will numb the whole flank. So those are just examples of procedures. Now, this is actually what's called an inverted L block. So a paravertebral block, you only block up here. You only block at these nerves. An L block is going to block any nerves that would be coming from the ribs and also the vertebrae. And you can see where the incision is going to be. So if I asked you on a test, what type of procedure could you do with an inverted L block or a paravertebral block, what would you tell me?
I'll take a stab. I don't think it would be a cesarean because it's too high, right?
Well, you could do a cesarean because the
incision.
Yes. Yeah, so in cattle, C-sections are standing. So they just they make this they flank incision. So this is called a flank. It's weird to think that you don't just open a C-section and lay them on their back. They don't like to lay cattle down, and a lot of times they're doing these out in the field with cattle. So they literally just make an incision. What's called, I'm sorry guys, it's called a flank incision. And yes, so C-section.
Yeah, I was right.
You were right. And thank you for taking a stab. And that displaced abomasum. This would only be in cattle. And then, or the abomasum. So you can do a displaced abomasum. Those are probably the most common procedures. You can do really some abdominal surgeries. Now, cattle don't get colic like horses do. Now, horses colic, they're in the hospital, they're on their back, that's different. Occasionally, like when we talk about horses, you can do in horses what's called an ovariectomy, where you're only removing, you know, they don't really get spayed, but if you remove the ovaries and you leave the uterus, they can't reproduce, they don't come into heat. So you can, and an ovariectomy can be a standing procedure in a horse. Now, it's not as common to be in the field and do standing abdominal surgery on horses. But again, remember, horses are considered companion animals, and people put a lot of money into horses. In cattle, cattle are primarily, food animal, and it's going to cost to do anything. So they're you're not really going to spend the kind of money typically, on a cow that they would on a horse. And horse owners are usually more than willing to bring them in the hospital if they can. And so here's kind of an example where the incision would be, where they block. And so the inverted L and the paravertebral block are very close to the same. Now, here's a couple pictures of, and I wish I could get this picture bigger. This would be one of the dental blocks. And so remember I talked about infraorbital. So if you had to do anything to the upper arcade, like say you had to pull a premolar, do an extraction, infraorbital, there's a needle going right here. It's hard to see that that's a needle, but you would feel, so see there's the zygomatic arch, and you would feel the most rostral part. And sometimes on dogs, they have like a little divot there. You can actually run your finger along the zygomatic arch and you can feel the divot. Well, they would inject, now this dog would be asleep. You don't do these blocks without, in a dog, you would do that asleep, but then you can do the block right there, that infraorbital block. It's a common dental block. And then here's an example of a corneal nerve block, which could be for dehorning. So I'm going to talk about that. So these are just different. And when you do these blocks, the difference is you're blocking a group of like nerves, and you can see that this nerve comes down and then it goes to these smaller nerves, and it's going to block all of those nerve fibers. So you're doing a bigger type of block with that technique. Let's see if I can get my PowerPoint back up. Okay, so paravertebral block, and I know it's not on here. Inverted L is a similar type of block. Corneal block for dehorning. The other thing is, let me explain lameness exam. If you have a horse that comes in and they're limping, or usually people say my horse is lame. They usually don't say my horse is limping. So lameness, they could have joint pain, they could have hoof pain. What the doctor usually will do when we do a lameness exam, so usually you run the horse up and down. We used to have to do this at Purdue. One of us would take the horse so the doctor could watch the gait, watch them run. When the doctor decides which limb or which joint they think is affected, they would do a joint block. And if you numb the joint, then they would say run the horse. And if the horse all of a sudden isn't lame anymore, then they've isolated the problem. So a lot of these lameness exams in horses, you end up doing these blocks, and that kind of helps the doctor because if a horse is lame on its left front leg, well, which joint? Is it a hoof issue? Is it a carpus? Is it the shoulder? Sometimes they've narrowed down the limb, but they still don't quite know where the pain is. If they block a joint and then the horse runs normal, they've taken care of the pain with the joint block, and then they've isolated, and then then maybe you need to do x-ray, and it's not that it cures the problem, but it defines where the problem is. So these are all types of nerve blocks, and I do want you to be familiar with, obviously, if I told you you were doing an intercostal block, you'd have to be doing some type of thoracic surgery because those are the ribs. A dental block or an infraorbital block, you're doing something usually to the jaw or the teeth. And a corneal block, you have to be doing something to the horns. Do you see how the names of these blocks give you an idea of procedures that could be done? I don't know if you're talking much in large animal about different surgeries. Are you guys in large animal 1? No, 2. 2. Okay. So I don't know if, he's talked about different types of procedures that are done in large animal. Yeah. So in cattle, or all you got to do, I'm not a huge fan of Dr. Pole, but I would say the things that he does when he goes to the farm is pretty standard procedures. Cattle typically will have like a prolapsed uterus, or they have to have a C-section, or their abdomen or their abomasum is displaced, their LDA, it's flipped sides. So these are all kind of common, and nerve blocks, because especially in cattle, you're not doing usually full general anesthesia. A lot of times you're doing this with sedation and nerve blocks because you don't have the hospital. You don't have all the gas and all of the special things that you can do. Now, when we do a line block, you're infiltrating local anesthetic somewhere between the surgery and where the nerves go to the spinal cord. Normally, you do a line block exactly where surgery is going to be. So you can use it in food animal equine surgery. If you have to do surgery on the teat, you can inject lidocaine up into the teat. An L block was just, no. So when I talked about the paravertebral block, that is in a line, except that's not where the surgery is. The surgery is in the flank. So the line is up here. Normally a line block goes where you're going to do surgery. Remember I said during C-sections, sometimes we'll do a line block, and I will put lidocaine all down the midline of the abdomen, because that's where the doctor is going to make the incision. So normally it's just putting it in a straight line, and it's going along where an incision is going to be. So well, if you look in this picture, this is now, this kind of goes to you, Sean, what you were saying, but this is just putting it in a line. Now, if you look, they're only blocking these 2 nerves, but that's really where the surgery is. An inverted L is going to give you, it is a line, except it's 2 lines, and it's an L that's been flipped. So that's where it gets its name. But look at all the nerve roots that you're blocking. So you're going to get a much wider, you can see this red box, you're going to get a much wider area. You're going to have more area to do surgery, and you're going to get more pain relief in the inverted L. But this is the abdomen. And sorry, let me get to the... So some of the other techniques you can do, you can actually inject directly into the joint. So a lot of times in horses, again, during lameness exams, and anytime you do, I haven't talked about how to necessarily prep. If you're going to inject into a joint, you're going to shave a square and you're going to surgically prep it, because if you put a needle into the joint, and usually we have to use longer needles, most of the time for these joint blocks, a lot of times we end up using spinal needles. And a spinal needle is usually a little bit stronger than a hypodermic needle. And it usually has a stylet that goes down the middle. And it has, and so, because what a spinal needle does, we use these for epidurals, we use these for these blocks. As you're pushing the needle through the skin, the stylet is protecting the inside of the needle, because you don't want to drag all that skin and subcu into the joint. So once you pop, usually the doctor, you'll feel like a pop when you go through the joint capsule. Then they pull out the stylet, and then they attach the agent, and then you can go ahead and push in the drug. So a spinal needle is just a different type of needle used for these procedures. So in an If it's articular, it's in a joint. Articular is a joint. And if it's regional anesthesia, then a nerve plexus is an arrangement of many nerve roots. So a plexus is usually, when I talk about the brachial plexus, there's many nerves coming out of one location and then they kind of split off. If you block at the plexus where they all kind of come out, that's like a larger group of nerves. And this can numb an entire limb or an entire portion of the body. Here is a better description of the paravertebral block for standing. So a laparotomy, of course, you guys are in surgical nursing, is just an abdominal surgery. A laparotomy is opening the abdomen, and you can do that lots of different ways. But a standing laparotomy, you have to do a flank incision or cut through their flank, and then you get into the abdomen laterally. And you're going to block at the branches of T13, L1, L2, and usually then, they kind of go caudal, and you saw on the picture I showed you how they blocked those nerves. Give you wide anesthesia. You can get some hind limb weakness. Scoliosis would be like a long-term thing if it's a little bit younger, but normally in an adult cattle, we're not too worried about that. But you do worry potentially because when you block, remember when I said you block sensory nerves and you block nerve roots, you're also potentially affecting motor nerves. And those are the nerves that control muscle movement. So anytime you block large nerve roots, you do have to worry about, weakness, stumbling. Again, you are kind of forward. You're only at L2, and they're going to have L3, L4, L5, but the spinal cord ends around L4, L5. It narrows. So we're not, L2, you're still, you're almost at the end of the spinal cord, but those caudal nerves are what control the back limbs, and that's what we worry about. Now, a common technique that I do want you guys to be familiar with is an epidural, and this is used in small and large animal. This can also be done by techs. If you work in a specialty hospital, especially if you work in surgery, you can be taught to give an epidural. And what we're doing, the bonus is it blocks sensation of the rear end. It also affects motor nerves of the rear end, so your back legs. So it can, if you have, these are all the different surgeries you can do with an epidural. You have a tail amputation, anal sac surgery, perianal surgery. So if you're working with the, and the muscles, like if the dog has a perianal hernia and you have to repair that. A urethrostomy. Anybody know what a urethrostomy is?
Isn't that the surgery they do for cats that become blocked a lot to widen that urethra so they don't get blocked?
Exactly. So this is where they amputate the penis. That's literally what they do. They cut off the end of the penis, and down the middle of the penis is the urethra. And what they do is they take the urethra, they cut off the end of the penis, but they take the urethra and they kind of pull it and they attach it to the tissues. And so they effectively make a male a female. And they're like exactly what Teresa said, they're making the opening wider. Some dogs or some cats are chronically get blocked. And, by the time you pay to unblock a cat and hospitalize it, my friend had to do it twice. Finally, the third time she was like, let's do this PU surgery. And I'm like, yeah, by now you've already paid for PU surgery. So, so PU, now I will tell you, practically being an ER tech, some cats that are getting PUs, if they're critical, need to be stabilized first. You know, if you're doing a PU surgery on an emergency basis, sometimes they're not going to want to take the time pre-op because maybe the cat is not doing well. Blocked cats can come in very, very sick. I mean, they can die sometimes in the hospital if they're too far gone. So it would depend, because again, an epidural takes time. But the other thing you can do is you can do these blocks post-op. So before you completely wake up the cat, if the cat does well under anesthesia, maybe you want to do a post-op epidural. So there's, most of the time we do epidurals before surgery. So they have the numbing for surgery. That's the benefit, is that you use less anesthetic, but they do take time. And sometimes procedures, if they're of the essence, you know, obstetric manipulations, you know, an epidural can be used for a C-section, but I told you practically in an emergency C-section, we are trying to keep the mom anesthetized as little as possible, because any anesthesia that goes to her goes to the pups, and respiratory depression, we worry about all that. But I will tell you, probably the number one reason we did them at Purdue was rear limb surgeries, cruciate repairs, fracture repairs. You know, I've worked with some orthopedic surgeons that sometimes didn't want an epidural because they wanted to see them walk or try to walk the next day. So it's kind of, but you know, for a routine stifle surgery, it gives you great pain relief. I had a dog that was having a TPLO. So that's one of the common cruciate surgeries that we do. And that dog was on a 0.5% isoflurane, 0.5%, because we had good pre-med, we did an epidural, the dog got an MLK drip during surgery. So that dog, I mean, the doctor was sawing into his stifle and screwing in plates, and that dog was on a 0.5%. And I've had people have animals on 3%. So it was like probably one of my best, and it just, that dog, it was a great anesthesia and a great analgesic plan. So it can be done. I do have, let me just, let me do something here. So this is just a short, oh, not that one. There we go. That's, So this is just a quick, these vet girl videos are good. I'm sure you guys have seen these before, but we're just gonna look at this kind of a quick how to do an epidural. So you do have to have sterile gloves. You are gonna surgically clip and sterilely prep the area, okay? And you do need a spinal needle. And so you can see, look at how this is a 2.5-inch needle. This is 3.5 inch, depending on how big your dog is. Because again, you're not going to be using a regular needle. You'll never get to the epidural space. So these are much longer needles. Usually you need a drug or a syringe of sterile saline. And then the drugs, you're either going to just do morphine, preservative-free, bupivacaine, preservative-free, morphine and bupivacaine. It depends on the doctor. So you can use a different combination when you do an epidural. All right, let me explain. And it's hard to tell because of this gray box here. This dog, well, this dog is in sternal recumbency, and no, we always did these, they were fully anesthetized. They have to be under general anesthesia. And they've clipped this leg. Usually we do the epidural first, then we do the clipping because we want to have the drug kick in. They've shaved a square, and what we're looking at here is if you feel on the dog's back, you're feeling for the wings of the ilium. And if you take your finger, your middle finger, and slide back and forth, if you remember anatomically, in between the wings of the ilium is where the sacrum is. And you're wanting to do L7S1. Well, if you feel the wings of the ilium and you feel the last lumbar vertebrae, there's a divot. There's a little divot in between L7S1. Now, when you take dogs' legs and pull them forward, think about the vertebrae. If you see my hands, if you pull their legs forward, pretend this is L7S1. You're going to take their legs and you're going to open up that epidural space. So normally, now you can do this in lateral too. You're kind of then going like this. I kind of like them in sternal. It's kind of personal preference. But the legs need to be forward. If you're doing them in lateral, someone needs to be pulling them forward. If they're in sternal, you pull them forward. And it basically is to open up that epidural space. And so she's palpating. You can see her finger is kind of in a divot. And this is all based on anatomy landmarks, okay? Because so the epidural space, so imagine you've got your spinal cord here, your vertebral column, you've got your wings of the ilium, you go right on midline, and it should kind of line up about at the level of the wings of the ilium or just right caudal. So you're just going to have to use landmarks and palpation. Now what they've done is they had the stylet in while they went through the skin and the muscle, and then they pulled out that stylet. There's a couple different techniques to know you're in the right place. She's doing what's called a hanging drop technique. So what happens is she puts the saline in that hub. As she advances the needle, when she gets into the epidural space, that saline will be sucked in. The epidural space kind of acts like a vacuum and it'll pull it in. And that's how she knows. I did not do the hanging drop technique, but what I do is I would have like a syringe of saline and I put a little air bubble in my syringe. And when I think I've popped through, you feel a pop. Normally when you get through the epidural space, there's a pop. And I would hook up my saline and I start to push it. And if it compresses the bubble, I'm not in the right spot. If the bubble moves with the drug, then I know I'm in the right spot. And that's, so there's a couple different techniques to know you're in the right location. So it just went in. Yes, when you pull back, obviously, so if, that drop went in, she's probably in the right spot, but you just don't want to make sure you get any blood, and you shouldn't pull back any fluid. If you do get spinal fluid or CSF, cerebrospinal fluid, you probably are going to pull the needle out and go into a different spot because then you've gone in too far. We're just trying to block around the spinal cord. It may be that you're too far forward. And I don't know if you could tell. I don't know if you could tell when she was pushing, there wasn't a lot of resistance, So you don't want resistance. You don't want to pull back and you don't want to get blood, those would be things that, you know, would kind of tell you're in the wrong place. So you don't want resistance, you don't want blood, you don't want CSF fluid. These are the different mixtures that you can use. You can use morphine, preservative-free by itself. Like I said, most of the time we mixed morphine and bupivacaine. The benefit of bupivacaine, first of all, it's preservative-free. It lasts longer. If you're going to take the time to do an epidural, we usually want a longer effect, but you can use lidocaine. It's just we worry about the preservative. Now we're going in the epidural. So the dura is the covering to the spinal cord and the brain. So epidural is above that. We're kind of going around the dura. And the spinal nerves pass through this space. So when you deposit the drug in the epidural space, all of those nerve roots that are coming out of the end of the spinal cord, that's what we're blocking. Now, they're going to block both sides of the limbs. You may only be working on one side, but you're going to get a block on both sides. But we're doing it at L7S1. And we you know, the sensory blocking is what controls the pain. But you may have a motor block that affects, you know, they may not be able to wag their tail. They may need help getting outside. If they're in your hospital that night, they may not be able to walk outside. They may need a sling because, again, if it blocks motor, that's movement. They may kind of defecate because they're not controlling those muscles back there very well. Don't worry about a beer block. We're not going to go over a beer block. Now, I do want to mention you can give, well, does anyone have any questions about epidurals? I guess I should say that first. You can give it as a systemic infusion. You can give lidocaine, like I said, you can give it as it's part of the MLK CRI. I have sometimes, a lot of times lidocaine as an infusion is given to control arrhythmias. Sometimes if a dog's having VPCs, we'll give a dose of lidocaine. Now that's for a cardiac purpose, not necessarily, but it can reduce the general anesthesia. It doesn't produce CNS depression necessarily, but it does give some analgesic support, but that's not as common. This slide is, you know, anytime we do these blocks, you know, we worry about loss of motor function. When we do an epidural, we want the pain relief. We worry that they're not gonna be able to like walk after surgery again. It can last up to 24 hours, have to be cautious. Anytime you put these drugs in there, now if you accidentally go in a nerve, you can lose function of that nerve, and that's rare, but it can affect that nerve function later. You can get tissue irritation, and paresthesia is kind of like a feeling of an oversensitivity of that area. So sometimes it kind of has an effect that we don't necessarily want. That's not normal either. But what I want to stress is that we worry about allergic reactions. So when you give these drugs in the tissues, like a local or a splash block, you want to look for redness and flushing. But anaphylactic shock, if you were to use an epidural and they were to react, that's why they said anesthesia monitoring. Anytime you're going to put a needle in that space and give that drug, the big thing I worry about is systemic hypotension. So if the blood pressure starts to bottom out and the heart rate goes up because it's compensating, and the dog potentially gets really pale, or sometimes they can get really flushed, and you start to see a spike in temperature. Those are all signs that they're maybe having a reaction to the drug. And, you know, sometimes those dogs, I mean, we may have to wake them up and not do surgery because, you know, you really don't want to take a dog that's having an anaphylactic reaction and keep them anesthetized. So sometimes, you know, and it's rare, but it can happen. But you guys need to know, you're the one that's going to be monitoring the patient. How would I know that the dog I'm watching is having an anaphylactic reaction? So those are all things that I look for anytime I give an epidural. Those are all things that I'm watching very, very closely. And if they're going to have anaphylaxis, it's probably going to be in the first 15 to 20 minutes. I mean, you're probably going to see it pretty quickly. Now, could they get flushing of the skin and a rash post-op? Sure, but that's kind of more of a local reaction versus a systemic reaction. And that's what we worry about. Now, some of this stuff is, we worry about the systemic toxicity, trauma to the spinal cord, the sympathetic nerve block. So the keys for an epidural is you have to give a certain amount, and you can see how she was pushing it. She was pushing it fairly slowly, consistent, but slow. If you push too much too far, you can go too far up into the spinal cord and potentially block the sympathetic nerve fibers. And then your animal can't respond in a fight and flight. But, sometimes during surgery, we need them to be able to increase their blood pressure, increase their heart rate. And if we block the sympathetic nerve fibers, they're not able to do that. And that's not what we want to do. Okay, well, all the rest of the slides get into controlled ventilation and neuromuscular blocking, which deals with ventilators, so we're not going to talk about that. So I'm going to stop here. Do you have any questions?